This week on the BackTable podcast.
I mean, it is the robot to some degree, but it's mostly the access that makes this so magical, right? It's what lets the patients go home on the same day of surgery. It's what speeds up your surgery and lets me do 3 instead of 2 cases in one room in a day. It's basically the idea of regionalization and closed access and staying out of the peritoneal cavity. The SP is the easy button for that, right? I mean, it makes this so much easier. When I go back and occasionally do a multi-port retroperitoneal case now, it's terrible. I mean, it is, look, you can do a lot with multi-port retro, of course, but it is quite awkward compared to what we do with the SP. So for me, the excitement has been the transvesical, the extraperitoneal, the retroperitoneal surgery. And even though I was essentially almost exclusively a transperitoneal surgeon, I probably do 85%, 90% extraperitoneal surgery now.
Hello, everyone, and welcome to BackTable Urology podcast. This is Mihir Shah, your guest host this week, and I'm really excited to have 2 awesome guests join us this evening. One of whom has directly played a role in my career and the other indirectly, and he may not even realize it yet. So he's about to find out. First, we have Dr. Richard Link. He's a professor and Carlton Smith Endowed Chair of Urologic Education at Baylor School of Medicine in Texas. And alongside, we have Dr. Michael Stifelman, who is the chair, professor, as well as director of robotic surgery at Hackensack Meridian Medical School in New Jersey. And I distinctly remember my first exposure to live surgery. I was a sub-I at NYU, and Dr. Stifelman was doing this wicked, large, totally endophytic partial nephrectomy, and I was just, floored. And so with that, Dr. Link has been a great mentor and a friend along my SP journey, so I'm really excited. With that, welcome. How are you guys doing?
Terrific. Thanks for the invitation.
Couldn't be better. Psyched to spend some time with you guys.
Yeah. So, today our topic and my thought about having this conversation with you two as sort of the early adopters, thought leaders in the field of single port robotic surgery was that as I reflected on my journey, I wish I had some, guidance, if you will, or some insight into how to approach it. And I feel like I talked to some of my trainees, and especially in the early part of their training, they're fairly confused or lost. They're not sure how it fits into their repertoire. So I'm hoping that this will help, some of the early adopters get on the platform. So just for some background, Intuitive Surgical launched a single port robotic platform back in 2018 is when I believe there was an FDA approval for urology. And for those who haven't had a chance to see it in action or work with it, it is a single incision, 1 port. It's about 2.7 centimeters in size, and there's an 8mm flexible HD camera that's 3D, of course, and then 3 6mm instruments. And so that kind of changed the game a little bit of not only how many incisions we made, but the small areas that we could get into. And so I'm hoping to dive into that. Do you guys have anything out of the gates that you want to add, Dr. Stifelman?
I think out of the gates is find someone who'll do it with you, right? Like trying to get on this journey alone can be daunting, right? And when you do it, a couple things happen. First, you don't have one to bounce ideas off of. When you get struggling, you don't have someone to say, hey, think about this, look at your bottom, see where your schematics are. And the second thing about doing with someone, at least there's someone that's backing you, because there's a lot of people out there who are not going to want you to succeed. And they may not openly say that, but we all know that change is disruptive and it can be unnerving, especially when someone's been doing something for one way for such a long period of time. And now someone else comes in and says, look, I can do this better. And so I think out of the gates, find a partner to help you with this.
Dr. Link, how did you get started as a very early adopter, right? So I don't know exactly when you think you can recall your first SP case was, but how did you go about it?
Yeah, so I think I was very fortunate because I was in really the second wave of SP adopters. So there was a very select, very early group, and certainly Michael was in that group, that really got into the SP in an early point where there were a lot of things yet to be worked out. I think those were difficult times, and we lost a lot of people that were initial adopters because of those challenges. We didn't have the techniques, we didn't have some of the technology available at that time. But I was very lucky. I've been doing SP now for about 3 years, And when I got involved, there was already a community. There were already people that were experienced, they were very open, and I had a lot of help getting my program off the ground. I mean, I would call Michael up on the phone, I would call Mudahar Ahmed, I would call Jihad Kal. I mean, these were people that had been doing this for several years already, had gone through that very difficult early phase where sort of there was exploration and maybe some dead ends that got discovered. And so my journey got accelerated by that. And I think one of the things that's excited me and energized me, particularly about SP, is this community that we have. It's a very open community. This idea that, the rising tide lifts all boats, right? I mean, I feel that very strongly in this community. And I've never had any issues with getting help and advice from people when I would run into a problem. And early on in that learning curve, as Michael was saying, having that person to call, having that person send an email to, boy, I had a really tough day today. I just couldn't find X or Y, or I couldn't get this access, is really, really helpful. So I would encourage people that are getting into it now, is even better for you. There's even more information, better training, more people, more community, and you really should take advantage of that. And then the last thing I would say is that he's right in that there are people out there who don't want you to succeed, usually in your micro community, because change is frightening, right? And there are a lot of people that just don't want to do this. But the overriding community in this is actually very supportive and positive.
No, I mean, I could personally attest to that. I remember calling you one day, reaching out in my early days, struggling with some tough cases. And so it's been incredible personally. And I can't say it's been easy. The first few cases are definitely tough. So with that, Dr. Stifelman, as you got started as the very early adopter, right, in the first wave, so you were a really busy surgeon. How did you go about it? Was it full steam, I'm going to do everything SP, or sort of more selective on, here's where I'm going to start with, focus on a handful of cases specifically, or patients, or what were your thoughts?
Yeah. First of all, the way we approached it was like a program. This was not going to be a one-person show, right? So we were the number 9th system released in the world. And, to convince my department, and not my department, but really my administrators to invest in this piece of technology that we really had no idea how we're going to use it. I mean, we didn't know where we're going to use it, why we're going to use it, how it's going to be better, how many cases we're going to do. It was a big unknown. What was able to sell it was we had 5 really good urologists who had a tremendous amount of multi-port experience, who expressed true interest in learning this. So that was the first thing. We got it as a group. And what Rick was saying was so true. We lost 3 on the way, literally within the first 3 months, 3 of the 5 were out. So that really left but Mudahar and myself. And what we started to do early on is to say, we're just going to select days of the month that we're going to use this. We're going to find patients that we can think at least we can get through this thing and do it. So it was mandatory. We're going to do one case multi-port, another case single port. We said for myself, I was taking 3 days a month. He was taking 5 days a month. And right away, that jump-started everything, because now you have this commitment that you've given up your XI or your multi-port robot. You're going to do these cases, and it doesn't matter how long it takes. You got no choice. It's got to get done. So I think we learned, but I think that was an important, that'd be something I would say. So try to commit to at least 30%, if not quickly turn to 50%. And now it's completely reversed. I'm doing more SP than multi-port, but try to start off with committing to certain percentage of patients that you're gonna do this on.
I think you have to think about goals, right? I mean, why are you doing this? And the goal can't just be, it's a new technology and I want to dabble with it. I think you have to have a goal. That goal might be different for different places and different people, but it should be crystallized when you start. And it's, as Michael was saying, it's more of a programmatic decision. Maybe your goal is, I want to convert more of my patients to outpatient surgery. Maybe I want to get into the retroperitoneum and do more regionalized surgery. Maybe I'm interested in transvesical surgery. But having a fixed goal will help you not only in being successful and having, your eye on the prize, but also in interacting with your executives, administrators, and kind of all be on the same page about what is, potentially a costly and time-consuming venture when you first get started.
It's a great call out.
Yeah, I still remember part of my early SP training. We were actually right before AUA a couple of years ago in Chicago, I think. Simone was hosting the sort of hands-on lab. And I still remember Dr. Cow talking about his very first SP cases. He had the multi-port parked outside the room, just in case. I think about it even still when I got started, and I don't have the luxury to park an XI or, SI or what have you now outside DV5, outside your room. It's just, they're used. So as I was getting started, I was committed. If I'm doing this, I either have to get through it or there's no other robot coming in. It's just me doing this or potentially converting to open, if I'm in a real bad pickle. But when I got to Jefferson, there were already 2 surgeons doing it very early on, but having that support to call on my partner, hey, can you come in and help? Or, can you just hang around for the day? I know you could do your cases. You don't have to be in my OR, but like just phone call away where if I get into something, I know who to call. And that was hugely helpful, at least for me. Any thoughts on what you think is a realistic learning curve for this in each of your opinion? I guess we'll start with Michael.
I think if you're introduced to it early in residency, it's much shorter. And, we've seen that anecdotally, and we're actually looking at the data on this. But, I use this term pretty loosely. I'm not a neurologist, but neuroplasticity. I think if you're someone who's wired up and done 1,000 cases with multiport and you're trying to switch over, that's a little harder than a resident who's just learning everything at the same time and just like a sponge and bringing it in. Our residents do as much SP as they do multiport now, and they're able to switch back and forth. If in my own experience as someone who is wired for multiport, I would say it was at least 25 to 30 cases before I said, hey, I'm not banging my head against the console, and having this huge cognitive load and sort of headache almost at the end of the day. I'm starting to really understand it. But again, I'm going to switch back to Link. We have so many tools now that we can share information. We have telesurgery. I can log in to Rick's OR and he can log into my OR today. And by next year, we're going to be able to do it without even connecting through Intuitive. It's going to be all right in front of you. So when you think about that, we have the simulation that we didn't have before. We've got models. We have each other. We have videos. We've got courses. So I think that learning curve is going to decrease over time, especially as the younger folks get into this. What are your thoughts on that, Rick?
Yeah, so I would say 2 things. The first is just a caution that, success on learning SP is not just translating your XI procedure into an SP platform, right? It's really not, that's not the path to success. That's a very difficult path because they're really different tools. They can live together in your toolbox, but they are different tools. And then the other thing is I think about SP a little bit like learning a language, right? So, how long is the learning curve to learn Italian? Well, it depends on how much commitment you make to learning the language. And there's a point at which you make this leap and it starts to be internalized. But if you are very slow in doing this, if I do 2 cases a month for 6 months, it's going to be a very long learning curve because you're catching up every time you get back to the operating room. When I started, I was very lucky. I was the only person doing it at that time, and I had access to that robot 4 days a week. So I operated 4 days a week on it during that phase. And I got, I was doing 6, 8, 10 cases a week for the first 2-3 months. And that really sped up the process to the point where I felt like I was starting to be able to speak it, and once you get to that point, then you can slow down a little, but you have to get to that point and not drag it out over a long period of time. So I think that you have to, just as Michael said, I think you have to toe in a bit and say, look, I'm going to do this much of it. I'm going to commit to this and do enough of it that you can get over that initial, learning the language phase pretty quickly. It's hard to put a number on that, but I think, 20 cases is probably reasonable. But again, if you do 20 cases in 6 weeks, you're much better off than if you do 20 cases in a year.
Yeah.
The comment you made, Dr. Stifelman, about trainees is a good one because we've been fortunate. One of your prior residents is our fellow currently, Eitan Glucksman. And, he came in and hit the ground running because he already had exposure and background. So, and we've seen that with our own trainees, they get more and more comfortable. And them adopting between the two systems is much more seamless. And I think if you're sort of thousands of cases on deep into your career on an XI or multiport, it's a much difficult transition in the beginning. But that kind of ties into what Dr. Link said, and I think in the beginning we try to approach it like it's the same exact case. You're just trying to repeat what you're doing multiport, and I think that's sort of a mistake, to some degree, because
Oh my gosh,
the device or the tools are not designed to function the same way, right? Because of the strength and sort of the vectors, if you will, because you're coming through a narrow port as opposed to flailing out, all the way across a large multi-quadrant area. So I guess this would be a nice segue into, what are some of the obvious differences? Can you go into some of them between multi-port as a robot and then single port? But you want to add anything else before that?
I mean, I'm just thinking like everything you said is sort of spot on. And it always amazes me when people are trying to do the same operation with the single port as they do with the multi-port. It's like, we learned that within like a month. Like we started doing everything umbilically. And like after a month, we were looking at each other like, all right, like this is it? Like this is what we're doing? This is what the whole thing's about? And we were like, no. And a bunch of really thought leaders, and I think Jihad was one of them for sure, and others were like, guys, we're looking at this all different, all wrong. You're all looking at this like, let's just go in and make a little umbilical incision and say we don't have any hernias and call it a day. Like that is the mistake. You got to look at this as how are we going to do it differently? And he really challenged us. And a lot of folks like Mutahar and Jihad, and some said myself in some ways, really decided, committed to that and leaned into, we are not going to use this like a multiport. We are not going to go to transperineal. And I think the number one thing that made this successful, this movement successful, this, technology successful, is that we committed that we are not going to go through the abdomen. And it's like, and you think about it, it's so obvious. Every urologic organ is in the retroperitoneum. Every operation we did open was in the retroperitoneum. The only time we went into the abdomen was when we developed laparoscopy, because we had no other way to get to the organs. It was like too much going on. But then when we thought about, like, we went clear back, sort of old school to the OG, the original gangsters, who were like making a little incision here to take out the stone, we realized, wait a second, we can do this with the robot because that's what it's designed for. This like narrow access surgery. And so if anyone listening today, I would not go into the abdomen for very long, maybe for a couple of cases just to make sure you know how to use the tool, but get out, because that's not where the magic is. The magic for this is transvesical, extraperitoneal, retroperitoneal, not in the abdomen. And I think Rick is really focused on that. And I don't think you had to do a lot of retroperitoneal surgery or extraperitoneal surgery to get to that point. But I think, I know for sure, I can't remember the last time watching a video of Dr. Link's where he was intra-abdominal,
I mean, so if you're looking for a way to absolutely fail, your plan should be do 20 transperitoneal radical prostatectomies with PSP. I'll do 20 of those, and then I'll move on. That absolutely you will fail, because that is just torture. No, so my story is, he brings up a good point, right? I was never much of a retroperitoneal surgeon. I did probably 15% of my partial nephrectomies retroperitoneally, and kind of under duress. I mean, I trained transperitoneally. I did a lot of single site laparoscopy. Everything was transperitoneal. And for me, part of the excitement about SP that kind of came early on was this opportunity to transition to a totally different type of access. It's not the robot. I mean, it is the robot to some degree, but it's mostly the access that makes this so magical, right? It's what lets the patients go home on the same day of surgery. It's what speeds up your surgery and lets me do 3 instead of 2 cases in one room in a day. It's basically the idea of, regionalization and closed access and staying out of the peritoneal cavity. And this is, we talk about the SP is the easy button for that, right? I mean, it makes this so much easier. When I go back and occasionally do a multi-port retroperitoneal case now, it's terrible. I mean, it is, look, you can do a lot with multi-port retro, of course, but it is quite awkward compared to what we do with the SP. So for me, the excitement has been the transvesical, the extraperitoneal, the retroperitoneal surgery. And even though I was essentially almost exclusively a transperitoneal surgeon, I probably do 85%, 90% extraperitoneal surgery now. Whenever I go into the peritoneal cavity, it feels very awkward. It's been a while since I've done that. And that's really strange for me since I was I was the transperitoneal curmudgeon for many, many years.
It's funny you bring that up because I did my fellowship with Indy Gill and at SC, and they didn't have the SP there yet. And one of the things you always notice with Dr. Gill was that it didn't matter where the location of the tumor was, how big it was. He could do it all just transperitoneally because he's just a gifted surgeon. I mean, some of it was hard to replicate. No kidding. But so most of my early days were multi-port transperitoneal, and most of my routes were, transperitoneal. And then when I started with SP, initially I was scared. I was like, I'm not used to, low anterior access running up the psoas. Like my brain needs to adjust to the anatomy and kind of figure out where I'm at so I don't get lost. But now that having done, nowhere near the volume of SP surgeries that you guys are doing, but even then, I'm close to having done 100, and it's just amazing. Just being in the retroperitoneum or just being totally extraperitoneal for the prostates or transvesical. And interesting enough, and I think Dr. Stifelman is going to have something to say about this, but when I started, I very intentionally just did transvesical simples. That was where I started. And I remember distinctly you saying that's probably the worst case to start with because it's difficult. But as I think about it, I think that holds true if I was going to approach it very much like a multiport. If I'm so used to nucleating the whole adenoma and, try to pull it out of the fossa with your tenaculum, you can't replicate it. But I think now, just kind of piecemealing it through and keep working in small spaces, it's been amazing. I mean, the same day discharge rate, no CBI, smaller catheters, and I'm a guy that does HoLEPs too. So, I've had the luxury of doing it multi-port, single port, HoLEP, and it's been awesome. But the way I rationalized starting with that was some of the higher volume patients I was seeing at the time. So it was easy to book a bunch of cases quickly because I wanted to keep up at least 4 to 6 a month in the early period. I figured, hey, if I screw up, just extend the incision, bail myself out with an open, simple, easy enough, don't need another robot. And then I was nervous about oncologic outcomes if I was going to pick oncologic cases to start. I didn't want to think about, hey, did I get a margin here because I was still in my early learning curve, or, am I leaving any cancer behind? And this was benign disease. And so I felt, nothing to lose. So any thoughts? Because I remember distinctly Dr. Stifelman saying it's probably the hardest case to transition over with.
So I think Rick, to me, has taught me how to do this operation. So I think one of the things I fell into, and I thought it was so hard to start off with, was that I was very, I was stuck into trying to nucleate the whole thing, or maybe a piece of it and then go the other. And when Rick came and gave me a lecture and showed me the orange peel, analogy, I was like, the light bulb went off. I'm like, that's the way you do it. So I'm going to let Rick speak to that. I think, again, the fact that we have people that have done it, have written about it, have videotaped it, has shown us how to do it successfully, sort of makes that transition easier. I know for me, because of just my own experience, that was a hard case to learn how to do until someone like Dr. Link came around and said, by the way, guys, I think I figured this one out.
Yeah, I think it's a transvesical simple is a very interesting procedure. I mean, one of the things that's most exciting about SP is kind of the creativity element of it. We're surgeons, we want to have that creative element. And it was starting to feel a little stagnant, as we'd been doing multi-port robotics for 15 years and we were just doing the same operations basically over and over again. So transvesical simple has been a very exciting time. And I think it's a good example of a case where the mistake is to try to replicate what you do with the speed and power of the XI or the DB5. I think that is a recipe for, some street fights behind the bar, basically, when you do these cases. But now you're using some of these tools and kind of setting things up. It's become a very reproducible, pleasant case. So today we did a big prostate, and the chief resident took the third-year resident through the case. And I'm just sitting there getting bored again. It's gotten to a point where it has become a reproducible, predictable procedure. And that's been really fun, a fun journey to get there, because the way I was doing multi-port trans-abdominal simples, that wasn't working. I mean, I was having a couple good days and then some really bad days when I first started. So this has now gotten to a good place. But again, we're seeing lots of different people contribute to that. So I think you get out there, you listen to what people are saying, you adopt things that you like. For example, I started out my simple journey doing all with a remote suction. And I talked to Simone and he said, hey, you really should just use a transvesical assistant port. And that decision, and I don't use a transvesical assistant port for almost any SP cases, but for simples, that's made a huge difference to just make it predictable, a lot less hassle. It just worked great. And so that was an example of someone who'd been doing them a lot longer and just giving out free advice to get you out of trouble. So I think we have lots of examples of that throughout the whole SP, experience.
So, interesting enough, I haven't used a +1, like even the sidecar that someone describes for transvesical simple. But the one thing I do often is actually suction through the catheter. So as soon as like the rosy starts to look like it might be clogging, I just have them start to declog that, but keep rinsing and irrigating through the catheter. And that usually helps keep things at bay. And then the other thing has been the spatula has been a huge win. The scissor would just get shut, and it was just a struggle. But now like I don't remember the last time I did a multi-port simple prostate at all, and the outcomes have been incredible. And I don't know if you guys advance a bladder flap or not. So I started doing that in the beginning, but I don't anymore. And I think about my time with HOLEP, and I'm like, what's the difference? The cavity just epithelializes over time. And that saved me some time. And usually it's dry. I just, put a E-tape in there, dry it up, and just leave it be. And sometimes for some select patients, I'll advance a bladder flap. But especially for my young ones, I worry about if they need radiation later for prostate cancer or something. I worry about the trigone being in the fossa. Any thoughts on that?
Yeah, I mean, I'm a big believer in the complete reconstruction. I think it helps with bleeding. It helps with irritative symptoms. I've scoped a bunch of these people, a year out from their surgery, and I really haven't seen a lot of deflection of the trigone into the fossa, so I haven't been too worried about that. But I guess there's some controversy. I think we've gotten that anastomosis or that reconstruction down to a very straightforward, very rapid process. And so again, everybody does everything the way they want to do it, but I try to do that as completely as possible. And it doesn't take very long now that we've kind of gotten a lot of the bugs out of that process. Do you like to do that, Michael?
I just like it looks pretty. I just
pretty.
like
It's good
at
for the
end,
YouTube videos. Yeah.
where everything just looks pretty, and you go, oh, look, it's, irrigating clear. The other thing is, in some ways, it's a much easier anastomosis than UV anastomosis because it doesn't have to be perfect. You just take a bunch of big bites. I saw a great video today that I'm going to use next Monday from Rick on X, where he showed me the best way to get that apex, and like by splitting the anterior commissure. He was able to get all of that little bit of adenoma around the urethra and get that urethral stump really nice, maintain that posterior plate. So I think when it's set up that beautifully, it's sort of like, why would I want to take a bite out of that apple? This looks nice. So I tend to do it as well.
The goal, ultimately, we'd like to see this procedure move in the direction of an ejaculatory sparing treatment for BPH. And, to do that, there's nothing magical about what aquablation does, right? It's just preserving certain structures. And we have all the technology in the bladder to do that. So I think techniques to try to control what we do to the urethra, what we do to the apex are going to be the most important in trying to replicate some of those outcomes. So that's part of the reason we started doing this. But yeah, I love that approach because it takes a lot of that last little bit of the apex that is sometimes a little bit rough. It makes it very easy to just split it and do it from inside the urethra. So it's been a nice trick.
So make sure you follow Rick Link. Is it Rick Link MD? What is your
It's
call?
Robodoc X.
Robo.x.
X, yeah.
You will learn a tremendous amount. Anyone listening, go to that guy's website. His Twitter account, X account, excuse me. And every week it's another little tidbit of knowledge.
You're a must follow for sure, both of you on the SP space. But can you guys talk a little bit about just the subtleties of the instruments and how they're a little different than multi-port for somebody that has no experience with single port surgery yet? So, just the mechanics and the strength and things like that, the variety.
I mean, the biggest difference obviously is that they're not independent. So they live on a stalk and they move together, which initially when you start can be a little bit odd. But actually now I really appreciate it. And in fact, when I do multi-port cases, I miss it, because I can't move everything at one unit. I can't bank the way I can with the system. Initially when we started, there was a lot of discussion about weakness of the instruments. And there were a couple of generations where they got a little bit stronger. But I've come to the realization that that's not really a problem in most situations. In fact, probably part of the reason that the patients do as well as they do is because of that gentleness factor. We're not superhuman supermen in there like we are with a multi-port system. So that can be helpful. And I don't know if we want to talk about some of the newer instruments, but there's some very interesting new instruments that are kind of just about to be released that are going to be very helpful, that I found helpful.
Have you tried those, Rick? Have you tried the extended length?
Yep. There's a lot of benefit to them in certain situations. These extended reach instruments are not longer. If you think about the way the instrument is built, it has essentially like a humerus and a forearm and a wrist. And the humerus is longer on the extended reach instruments, but actually the wrist has more range of motion. So they have about 10 degrees more range of motion. So it's actually more XI-like in terms of how the wrist works. And then there's a force bipolar, which is a twice as strong bipolar instrument, which actually is really nice for simples. If you're used to doing, some grabbing and pulling kind of maneuvers, it's quite noticeably nicer to use. So I think that's going to become, a go-to instrument for those procedures.
Any issue in the transvesical space with the extended use instruments? Because we started using them, I think I only use it for retroperitoneal kidneys, and that's what I had on Monday, and it was great. It was wow, this is really making things a lot easier, especially suturing that upper pole, much more angles. However, Amutahar was telling me he didn't love it so much for transvesical. He felt a little bit limited. What are your thoughts? Have you used it for both? Any tricks there?
So it's great for cases where you have to do a lot of retraction with wider spread. So say getting to the upper pole where you're kind of pulling the kidney over and you're banking around that corner. There's more spread in the instrument. So that's actually really nice. I've done some transvesical cases with it. I haven't found that to be a problem yet, but obviously, the more cases probably to really get to the bottom of that. I do think the force bipolar, which is a extended reach instrument in the non-dominant hand, is magic. And
Gotcha.
So I really do like that a lot. I think that's going to be on the table every case for simples. I like the way the extended needle drivers feel. I don't know that it's that dramatic in that space. And I can imagine maybe in a radical prostate, in a very small pelvis where you're kind of going in underneath the pubic bone, that perhaps that could be an issue. But I haven't found it yet for the transvesical, but need to do more cases.
So, the instruments on SP are very different than XI for sure, right? And so you have to plan the operation a little differently. You can get some pretty good traction with your fourth arm, but you got to do some maneuvers, right? You got to flip the fourth arm into the 12 o'clock position. You got to go camera down to really get that sort of traction that you're used to, just where you with the XI just go whoop, and it's like, there's the kidney, there's the hilum, they're good. So, but going back to what Rick said, I think we have been able to compensate by being gentler during the surgery. And we went and we looked at, and I thought, and we actually put this out in Journal of Robotic Surgery, and was just presented at NARIS, because I had that same thought that Rick had, is that maybe the gentler surgery is improving some of our outcomes. And so we looked at that specifically in prostatectomy, and we found that actually it's true. Like our functional outcomes, our SHIM scores, our pad weights, our lower urinary tract symptom scores were all better on our SP cases than on our multi-port cases. And there are other variables that could have played into that. But I think it's a signal, and it's something that we should be thinking about, is that, why is it that our patients are doing better this way? And I think a lot of it is because we are doing gentler surgery because we have to. And I think the other thing about SP, which again, I'm going to double down with Rick and say, is it's one unit. You're going at this as one unit. And so that ability to look around, and get into that, above around the apex, or get into the upper pole, and rather than attack it this way, but attack it this direction because you've banked it, is just something we don't have in XI. And I feel the same way exact as Dr. Link mentioned, is that I miss it. When I'm using XI, I'm like, why can't I just, bank it, with everything? And it doesn't work that way. So it's a little bit of a different animal, but what isn't different is the anatomy. What isn't different is the planes. What isn't different are the landmarks. Those things are different, and so just the way you think, the way you approach it and some of the steps you may take are different. Some of the way you dissect things are different, but the actual doing the operation doing it retro, doing it extravesical, transvesical, it's all still there. It's still the anatomy is the anatomy.
Yeah, think about the transition that we made from laparoscopy to multiport robotics, right? We went from something that could be technically challenging to an easier way to do the same thing. In some ways, it felt like cheating, right? Because you could get away with a little bit of sloppiness with the multiport system, and you could brute force through it. Your wrist doesn't do that in real life, but it does it on the robot. So, and I think when you go from multiport to SP, it's a little bit different. It's a little bit more technique demanding in the sense that you can make your life difficult quite easily if you're sloppy, right? So, if you're getting your arms tangled up, if you're doing retraction kind of into the wrong quadrant with different arms, you can make things quite difficult. And that's where when you watch someone who does this a lot, it just looks effortless. I mean, I watch Mudahar do these cases, and it's like the Rosie is following him around like a puppy dog, and everything is opening, and it's just so effortless, right? But it is because you internalize some of these more advanced, tricks for retraction and visualization, and they start to be internal. And so you just do them automatically, and then suddenly everything seems easy. But early on, you have to do them kind of consciously. And I think it's a little more demanding than the multiport in the sense that it's a little harder to brute force what you're doing. So you have to plan a little bit more. We talk about maybe there's a little more cognitive load when you're doing SP because you've got a lot of options and there's a little bit more variables to manage.
I tell my trainees at least, get used to not parking your fourth arm for retraction and just yanking things to the other side, and get really comfortable with moving your instruments constantly in little spaces, readjust your retraction, move along, move forward. You're not sitting back, kind of torquing the prostate all the way to the other side as you work through one neurovascular bundle. You're kind of closer, smaller retractions, and you got to move your fourth arm with you and move the whole sort of, all your arms in sync, or else you're going to clash, right? And it forces you to be more thoughtful, and yes, it increases your cognitive load, but you can't get away with being passive and kind of just forgetting about your fourth arm, which a lot of the early trainees, kind of just park it and it never moves, or they're often just working with one hand. But that's definitely something that you need to think about actively as you go into this, because if you try to approach it the same way, it's very frustrating in the early periods. But you learn quickly. Either you give up or you stick with it and you adopt, at least that's what I've seen. It's easy to get frustrated.
Yeah, it's not for everyone, but you've got to have a goal that it really serves, right? If you don't have a goal, you're not going to stick with it, right? But if your goal is a good goal and it ties into the strengths of the device, then you're going to love it. It's just,
and I mean,
what is your goal?
There's a lot of benefits, yes, it's a smaller incision, or rather there's less incisions and it's not that big. But I mean, you talk about access, you're right in face of your anatomy much faster. I mean, we talk about lower anterior access and for retroperitoneal partials. And I mean, I feel like once you get efficient, you can get to the hilum in 8 minutes, 7 minutes, something super fast, which you're just not going to get to, even if you're really fast with the multiport. So it reduces your OR time. We talk about less pain, obviously. And then we get away from this really awkward positioning we've been used to for so long with very steep to Nellenberg or really flank positions, which, anesthesia doesn't love you because the arms are all tucked, and here you can be supine. It's just more ergonomically comfortable for the patient and less musculoskeletal related issues. And then, at least in my experience, the length of stay has been much shorter, secondary to likely, much less pain.
Michael is a real, thought leader in the reconstructive space. I'm kind of interested in what your thoughts are on how the SP has changed your reconstructive practice. Is it a big part of what you do? Is it the majority? How does it play out for you?
I've converted everything to single port now. And I've converted 85%, if not more, of what I do to retroperineal approaches, including reimplants. Certainly all my pyeloplasties, certainly my buccal mucosas now are going retro and using psoas as for the graft site. Probably the only times I'm going in transabdominally is for ureteroenteric strictures, just because they're already in the abdomen. So I gotta go that direction to get to it. And even in that scenario where you're sort of, everyone's like, I don't want to touch that. That's the hot potato. Open, opened conduit or an open neobladder with the left ureal stricture. Let's just keep stenting him. That's a great case for an SP, because you just kind of work your way, tunnel your way to where you need to be, slip a ureteroscope in, find exactly where the lesion is, where the problem is, and just deal with it right in front of you. So I love SP. I think it's a perfect fit for this. And what I'm also excited about is for the other service lines to start using this. We now finally have thoracic surgery. Our team is using it for thynectomies, no longer going subcostal, going subxiphoid, much better visualization. They're starting to use it for colorectal. And I think this train is at the station. And if you're listening, it's time to hop on the train, because you're going to be left behind. And that's my opinion, right? But I think there's, like, for everything that was said tonight, there's so many different advantages that are quantifiable. And the three of us, we're all believers, right? So we've all drank in the Kool-Aid, but we look at each other. They look different. They act differently after surgery. They feel differently. When you see them 1 week post-op, they just are, you wouldn't know they had surgery, versus even your multi-ports, they're different. So I think from that standpoint as well, it's a huge benefit.
And the one thing we didn't even talk about yet is, the quote unquote hostile abdomen, or, multiple prior surgeries. I mean, these are all these patients that often we would try or abort, or, didn't think they were candidates for multi-port surgery because you were doing 3-hour, lysive adhesions, enterotomies, et cetera.
I would give you the perfect example. On Monday, there was a guy, I don't remember what his XLAP was for. Maybe it was a colon perforation. He went to a urologist. They went to do a multi-port. They peeked and shrieked. They were like, and this was a good urologist. Like, I know this urologist very well. He's a friend of mine. He's done 1,000 of these cases. He looked at it as like, there's no way I'm taking this down. I got a buddy of mine. You can go 30 miles up the street. He'll take care of you. And it was a perfect scenario. And this is a guy with, high risk disease, 65 years old, otherwise healthy. And it was just, we got stayed outside the abdomen. And I'm sure Rick's got, we both have, unlike yourself, hundreds of stories with this. And it's huge, huge win.
Yeah, we talk about this a lot in terms of benefit to the patient, and there are benefits, but there are also benefits to the surgeon, right? Not just in terms of efficiency, but also in stress. There are patients I'll see in the office, and previously I would have thought this is going to just be a long, painful day. And now it's almost cheating, because you're completely avoiding all that stuff. And we did a redo horseshoe kidney partial for an endophytic tumor in a guy with an XLAP last week. And it took like an hour and 40 minutes or something, and there was none of that struggle, access. I mean, it was just super straightforward. And I feel like I feel the same way about the reconstructive world. I mean, you do a couple of retroperitoneal pyeloplasties through low anterior axis, and you can't believe that you were doing it this other way before. And so, I think that it adds a whole new element to what you can offer. And it also takes a substantial amount of stress away in certain situations. Now, obviously, you have to get to a comfort level with the technology and the access and all those things. But once you do, there's a pretty big payoff at the end.
I had a lady who had a Wallace for her ileal conduit from a cystectomy 20 years ago, who then had an upper tract recurrence on the right side. She, BMI is like 36. And I was really worried, multi-port obviously prior surgery. How am I going to get to the anastomosis and reconstruct it? If I do it open, it's going to be a huge incision. And, those are notoriously difficult to find. And then to do the reconstruction on the left side to the existing conduit. And man, it was effortless with the SP. I was able to take down the Wallace and just reattach the left side to the conduit. And I just imagined that would have been really difficult any other way. And, the patient went home next day. And I just can't imagine.
So walk me through how you did that. You do that retroperitoneally?
No, transperitoneally, but I used the larger beach ball, if you will, supra-umbilical. So, because I knew the conduit would be on the right side. And so first did the kidney part, traced the ureter down to the Wallace, then disarticulated the Wallace on the stump of the conduit, took off the entire right with the cuff, if you will, a Wallace cuff. And then there was enough length on the stump where I could just resew the left directly to the butt end of the conduit. And
Awesome.
it was minimal lysis, it's used supine and with a little bump, just like you would an FRU. And I feel like it was a game changer. I feel like it would have been really a bear. I could get it done, but it's a bear every other way. To see it as well as you do with the SP, because you can flex up, flex down, and it's like, oh man.
Even a transperitoneal approach to a transplant ureteral reconstruction is just really nice. You just sneak up underneath and you're right on the target.
Oh yeah, I've done about a half a dozen now transplant ureteral reconstructions. So this patient this person came to me, this transplant surgeon said, we want to do a nephrectomy on the native kidney so we could use the ureter in order to bypass the stricture. I'm like, what? I'm like, why don't we just do a side to side? I'm looking at the film, like there's like 3.5, 4 centimeters of good ureter off the transplant kidney. I'll just go in there and free the bladder up and just do a side to side. They're like, oh no, it's gonna be too messy. You can't do that, blah, blah, blah. So I'm like, do me a favor. Let me try it. Okay. And if it doesn't work, we can go plan B, and all of a sudden I had the whole transplant team in the room. They look at each other like, this is it. That was easy. And now I've gotten like 6 more that have been referred to me in the last 3 months. But, it's these aha moments, right, that you have with this technology. And it was the same back with multiport, when you had these aha moments. The question I ask you, Mihir, is, what do you do for those attendings that you have in your department who are looking at you like, you're stupid? Like, what are you doing this for, Mihir? Is this just some sort of gimmick? Like, why are you torturing yourself? Why are you doing this? How do you get them on board?
For one, you got to believe in what you're doing and what your goal is. So the easy way to do is by tracking your data, right? Because data matters. So if you can just like objectively show a difference and a benefit, then I think the naysayers have a harder time. And then be realistic. And for me, I was very intentional, kind of alluded to my practice, currently it's probably 35% SB. I'm still in that early phase, if you will, but it's more, and now I've expanded, cystectomy, FRUs, partials, RALPs. And so, but I was intentional in the beginning saying, hey, look, I'm going to do something that I feel is low stakes, maybe a struggle, maybe difficult, but I think I can get through it safely, have a good patient outcome, and then demonstrate feasibility clearly, but also a benefit. And I think that's sort of how, I've won a lot of folks over in the sense that I now get referred, certainly to some of the very large glands where I do them single port. And I mean, like I said, I even do HOLEP. So I talk about both of them and I'll do them. And now I will be honest, I was most hesitant about switching my multi-port RALPs, largely because I was really concerned about lymphocyles. And so, but now I do them as well. I actually have 2 SP cases. I actually have a VVF transvesical tomorrow, potentially. But, I think we've worked through it. I did have some lymphocytes in the beginning, but now I clip everything and it's worked and we've decreased the lymphocyte rate. And so it's been a challenge. Certainly there's definitely some folks that are still skeptical, but I think if you can track your data, you learn from it, and you make changes and you talk to colleagues who are doing this longer and have been through the trenches. And, I've relied on you, Dr. Link, and it's been really helpful.
I think it's important to differentiate between people who don't want to do it and people who truly believe there's no value in it. I think those are different things, right? And so we have some folks in town that don't want to do it. Taking the approach of just being supportive in that and just letting them know what's out there and what you can offer to help them in certain situations. And you will attract some referrals for the kinds of cases that you knew were going to be very difficult to handle using traditional transperineal multiport surgery. And I think that the truth is that the value of it isn't really in dispute. I mean, you get some very, sort of almost angry kind of statements about how it's not valuable. I don't really think that makes a lot of sense. On the other hand, not everybody needs to do this, right? And not everybody wants to do this. Not everyone has the practice capacity or interest or capacity for pain to do this. And that's okay. I mean, that doesn't have to happen. Not every case has to be done this way. That message is probably not the one that resonates most with potential practitioners. I think this is just a tool. And again, for myself, I started out thinking this was going to be almost, maybe 20% of what I did, because I was already doing single site laparoscopy and multiport robotics and a little bit of retro stuff. And I thought, well, I'll do maybe 20% of my cases this way. But as you get comfortable, it becomes addictive, it becomes, because the efficiency, the outcomes are so good. So you may find that you will end up doing a lot more of it. And you can see people that do this a lot are doing 80% of their cases this way. It's, pretty powerful. But I think, you're going to have some resistors, and that's okay. Not everybody has to do everything.
Just curious, I'm gonna get a little controversial here, right? Are you surprised, Rick, that with the adoption of SP over the last 6 years, did you think it would be more, less, the same? That's part one question. The second part of the question, a follow-up is, if you're a surgeon out there today and you're doing 200 or 250 multiport robots, do you think that they should be reevaluating the way they're doing things? Or do you feel that, well, you got to believe in it. You got to have a reason. You have to have a goal. Or can you really say that? Or do you think they should be pushed a little harder by their colleagues?
Yeah, I mean, I'll join in on that controversy. I mean, I think this is the future of what we're going to do, right? I mean, you can get on the train early or late. If you get on the train late, you just have the costs. You don't have any of the benefits, right? If you get on the train early, you get the benefits and the costs. So there's a benefit to that. To put a corollary on what you said, I'd say I'm surprised by the resistance that you see, which is interesting. I do a fair bit of proctoring, and it's interesting that there's still a lot of resistance 6 years in, right? Which is interesting. I don't know if that's a function of sort of the challenges that happened in the early years where it didn't come out of the gate as an absolute game changer. But I do think that is interesting, especially just based on my experience with it, where it's been so transformative to my practice. And my practice was fairly mature at the time that I started doing this. I mean, I'd been in practice 17 years at the time I started SP. And so it was very transformative. So yes, I am a little surprised by that. I think if you are a transperitoneal multiport surgeon who is doing surgery the way you've done it for the last 10, 15 years, you're not doing yourself a favor by just writing this off. I mean, it's a real thing. It's not we talk about the dinosaurs looking up at the sky, is there an asteroid that's going to come and end their world? And, some things aren't, last single site laparoscopy, that wasn't a real asteroid. This one is pretty real. I mean, I think you probably want to be involved in it. And that's going to become more compelling as we train more and more and more people, as all these people that come to, say, your SP conference and go out and want to practice. I mean, our residents are graduating and they're looking specifically for places that have SP access. They don't want to take a job that doesn't have SP access because they've discovered that it's such a big part of the algorithm for how you treat patients in 2025. So I think that as more and more of these younger urologists finish their training and go out into the community and start doing SP, it's going to become more and more uncomfortable for those that have just hands off, this technology.
I just want to follow up with that. Those are great points. It's more of a comment. And the reason I bring this up, because I realize this podcast is not speaking to the 55-year-old urologist. This podcast is speaking to the residents and the fellows and the medical students. So the reason I bring this up is, don't be discouraged when your chairman, your vice chairman, the person you look up to is like saying, you don't need to do this. This is going to be a fad. Just don't worry about it. So, and the reason I say that is this is a very similar story when we started doing robotic partial. So in 2004, a year after I got the robot, I presented my first set of data with Sam Baiani, I think Craig Rogers, the three of us. We 150 robotic partials. And we were torn apart at the podium. We were told by everyone, we're going to bankrupt America. We're going to bankrupt healthcare. You just need to learn how to operate. You guys don't know how to operate laparoscopically. If you knew how to operate laparoscopy, you would never need this. It's just a sewing kit. It's a sewing tool, and I was pretty discouraged, but I also knew that I was cheating. I was as good as any of these guys now, or women who were doing these 50 cases laparoscopically. I was as good as them, if not better, with this tool. And I think the same thing you're going to see with single port is that as a young attending or fellow or resident, you may be at a program, you don't have it, or if you have it, there's a lot of people who are suggesting there's no benefit. And I would say, if you believe in this, that's all you need. There's benefit, and go and I would encourage you to follow this and get involved early, because like Rick said, when you get on the train early, you get decreased cost and a lot of benefit.
Yeah, and I think we're examples. We were in our 50s when we took this on, right? We're straight out of fellowship. And, there's always a challenge in trying to identify technologies that are transformative and not invest your time and energy and resources in everything, right? I think this one is clearly transformative. So I would strongly agree with you that this is not something to just write off as a fad. And as long as we continue to have investment in the technology and advancement in the technology from Intuitive, we're going to this where we are in 5 years is not going to be recognizable. I mean, think about when we started on the standard robot. What would we would have never imagined the stuff that we were doing on the XI at the time, 10, 15 years later, right? So just extrapolate that to the SP. Where are we going to be when we're at version 5 of the SP? It's just inconceivable.
Dr. Stifelman already kind of answered my question. If this feels, and it's, I feel like I'm too early career to know, because, I feel like I count on my fingertips how many open prostates I've done or seen, right? And so I feel like the transition to this may be similar to the initial transition from, open prostates or open kidneys even to the lap, and then to the robotic, where there were a lot of doubters. But clearly, if you look back now, it would be unimaginable to be still doing open prostates.
And think about who was resisting, right? Every resistance effort is the previous innovator, right? So when we were doing laparoscopy, it was the open surgeons that were against it. And when Michael moved to the robot, the laparoscopists were resisting. And now when we go into single site, we're seeing the multiport robotics.
There's literally a term for that, which is innovation stagnation, which is that a concept, and I hope none of the residents coming out ever fall into this trap, but the idea is that you innovate and you spend so much time innovating to do something that's the best it's going to be. You cannot do better, and anything that could be better can't be better, because we spend all this time innovating to this point. So, don't fall into that trap of innovation stagnation. It's a real thing. And I think one of the reasons why we also like it, both Rick and I, is it's fun, it's challenging, and when, and it really helps the patients. Like at the end of the day, my patients are so happy with me, and they should be, because they're leaving the hospital the same day and they feel great versus their colleagues, it's not always that case.
This is great. So final thoughts on, for the listenership as we wind down, what are top 3 recommendations you would give to somebody that's just, does 100, 150 robotic cases, mostly multiport, entirely multiport, I guess, had multiport in their early training, so residency and then maybe fellowship, and is looking to get into single port?
I would say 3 things from my perspective. The first one is don't do this alone, right? Don't force yourself to drive over every speed bump by yourself. You can be a great experienced surgeon. You don't need to hit every speed bump. There's lots of people to help you. There are lots of resources. Intuitive has a lot of training pathways. There's lots of information out there. So definitely get some buddies and do it together. The second would be just regionalize right away. Don't, even if you're not that comfortable with regionalized surgery, just start your journey there. You'll see a bigger, the juice in the squeeze. You're going to see a more juice from that squeeze than you are from doing a series of transperitoneal procedures. And the third, I would say, is just, if you're going to get started on this, just commit a reasonable amount of your time and effort to it. Don't try to dabble, and spend a year doing 15 cases. You need to toe in and do enough cases that you'll make rapid progress.
I would double down on Leverage Intuitive. There's incredible resources there between the SimNow and the telepresence and all of the videos from us, and that join our community, come to Spark, come to SIRS, come to the AUA, find people that are like-minded like you and get together. And in terms of picking your first cases, a little hard sometimes, but I really do think that being intentional for those first 20 cases, make sure you're not just doing it because that's what landed on your plate today, but that you could get it done. You want those early wins, right? So you don't want to pick a 10p nephrometry score on a solitary kidney who maybe had a previous hysterectomy, and that's the reason you're doing it. You want to pick that, female, not a lot of fat around the kidney, easier tumor. You want to pick that 30-gram prostate that maybe you don't even have to do nodes on, that just is a Berganti 2.0. You may want to pick that 150-gram prostate versus 350-gram prostate. So get out of the retroperitoneum, pick carefully those first 10 to 20 cases so you get those wins, you get that comfort level, leverage the heck out of Intuitive, make them send you to courses, get them to get you proctoring, telepresence, and don't dip your toe in the water, commit to it. And then finally, track your data. Just like you said, Mihir, it's so refreshing to hear someone tracking their data. I know it's huge for us. No surgery is done at Hackensack University Medical Center unless they're put into a prospective database. It's like a rule. Every patient is in a prospective database because we want to know. We want to know when we're doing it right. We want to know when we're doing it wrong. And I think that is super important. So, get in the habit of that. Even though you have an IRB, it's still your own, still can be, you can still evaluate your own stuff without publishing it. And I think that's really important. Mihir, congratulate you for that as well.
Completely agree with everything you guys have said. I would only add that, the BMIs that are more favorable are probably ideal. So you're not contending with a lot of retroperitoneal fat where you're getting frustrated or lost. Similarly with prostates, don't go too big for the RALPs, 60 or under probably, right? I think most of us would agree. Maybe don't start with your high risk with ECE where you're worried about, leaving a margin behind, and if you're starting with transvesical simples, 100, 150 is the sweet spot in the beginning until you get really familiar, and then try to go piecemeal it. Don't try to enucleate the whole thing. You're going to get real frustrated really quick. And so reach out to any of us. We're all on X, and you're going to have our emails, and it's a close-knit community that's there to help each other. And it's been a great journey for me, and I'm so excited to be able to spend this evening picking your guys' brain. And truly, I'm leaving learning a lot myself. And so I thank you guys for your time and look forward to seeing you guys at the AUA.
Thank you for having us.
Thanks for the invitation.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.